Today we're going to use Dominic here to demonstrate how we run through the process of the leg checks that we use for our drop table corrections. As we look at this, Thompson protocol is going to dictate that we start in the cervical spine, work our way to the pelvis, and then we're going to go ahead and wrap with the sacrum. Once we complete that, we'll go ahead and work into our thoracic and lumbar adjusting and finish with our upper cervical specific technique if that's deemed necessary by your exam. To start out the leg checks, I'm going to have Dominic push out against my hands, and the goal here is to reset proprioception so that you get a more natural representation of what is going on with the leg links. When the patient lays down on the table, you want to make care to try and get them on in a way that maintains that symmetry. I've talked in class about the high-low tables where a patient will stand on the table and it will lower them down. This is one of the other ways that we help to maintain that gravitational representation. Once we've done so, we're going to use our three-point contact. Our fingers are going to split the malleolus. We're going to depress gently on the calcaneus just to take the slack out of that subtalar and talocrural joint so that we get an honest representation. And we're going to sight between the malleoli on the medial side at the base of the heels, or if they're wearing shoes, you use the heel counter, which there's a demonstration in the presentation on how to do that. We're going to take a look, and I notice that he's got a slight left short leg, and at that point, we're going to ask him to turn his head to the right, and then we're going to recheck our assessment. We're going to ask him to look back down, and then we're going to ask him to turn his head to the left and recheck our assessment. You can look straight down. What I noticed in this particular case is that when he turned his head to the right, there was no change. When he turned his head to the left, that changed the leg links. And ultimately, that's what we're looking for, is a connection between the cervical spine and the leg links that would show that if we adjust it, we can correct for that. So in this case, you would treat that as a left rotation, subluxation, or dysfunction in the cervical spine. After we've completed the cervical syndrome check, we're going to go ahead and adjust the cervical spine to clear. We're not going to do that today for obvious reasons. From there, you would go to check the pelvis. And with the pelvis, we're going to use a Deerfield check. So we have that short left. We're going to flex the knees to 90 degrees. And we're going to look to see, did that left leg stay short or did it get longer? If that left leg stays short, that would be representative of a negative Deerfield. We'll represent that as an AI sacrum. If the patient has a short leg that goes long on that particular side, that would be representative of a Deerfield positive. That would be analogous to a PI ilium or a posterior inferior innominate. Once we've completed the Deerfield check, we're then going to go ahead and move to the sacral leg check. So I'm going to find his sacral base. I'm going to palpate on the sacral base. Now I know in the presentation it talks about the fingers being pointed downward. That's completely acceptable. Just don't hook your finger underneath. Or you can just hold the sacral base. The objective here is to, one, stabilize the sacral base during the movement, and two, to be able to feel when that sacrum starts to nutate and counter-nutate instead of the legs extending. That's going to give us an honest representation of the mobility assessment in that sacroiliac joint. So I'll stabilize here, and I'm going to ask Dominic, keep your knee straight, lift your whole leg up off of the table, and then go ahead and put that down. Let's see the other side. And you'll notice that his left leg doesn't lift as high. Now, Thompson protocol is going to say that we're looking for at least a 6 centimeter variance between the two. Personally, when I evaluate this, I recognize asymmetry as asymmetry. So as long as it correlates with the rest of my findings, I'm more commonly going to adjust even with a slightly more subtle variation between the two sides. So at this point, you would go ahead and correct the sacral rotation, and we'll talk about that a little bit later.